Good evening, everyone. Thank you for joining us. We have Dr. David Smith here to talk to you about knee problems.
Hi, everyone. My name is David Smith. I'm an orthopedic surgeon, practice at Ingalls, part of bone and joint orthopedic practice. Tonight we want to talk about knee problems, some common knee problems, and I wanted to start off with this slide. Total knee replacement is not the total answer. Because I see a lot of patients who have been told they have knee arthritis, and I think for some of them they feel the only approach is to just live with it or have a knee replacement. And certainly we do a lot of knee replacements, and I think it's an excellent operation. But I want to talk to you about the broad spectrum of things that can cause problems in the knee and some of the approaches short of replacement. So some of the common problems I see patients coming in for, complaining of pain, instability, and stiffness. This is something that I've been doing for years. I read when I was just starting out in my practice, I read an article in the paper that people were saying what they didn't like about doctors, and it was quite a long list, but they said that we didn't communicate that well with people, and one of the questions put to those responding was, what do you want to know? And these three questions came up, and I've always tried to remember them. When a patient sees a doctor, really they want to know what's wrong, they want to know what they can do about it, and they want to know how it can turn out. So tonight and every time I see a patient, I try and answer those questions. Sometimes we have to wait to get the answer, but that's the general goal. Answering the first question, what's wrong? I often use the example of Sherlock Holmes. It was a fictional character written by a Dr. Conan Doyle, who patterned him after a famous physician in Scotland who was excellent at making diagnoses. So we use him as our inspiration. And the great detective always started out by gathering information. And we do that in medicine by a variety of ways. These are all of the elements: patient history, physical exam, x-rays, ultrasound, and MRI. And it's really important when you come to see a doctor is that it helps me a lot if you just tell me, what the problem is, what it keeps you from doing, what treatments you've tried, what concerns you have, what goals you have. In other words, are you a person who gets back to running, or just somebody who wants to get back to being able to play with the grandkids? So physical examination, the hands-on, despite all the fancy tests, the physical exam is still a very important thing in helping us reach the answer to that question, what's wrong. Do a lot of x-rays. I had a lady the other day came in and took some x-rays, and she'd already had some, and she goes, how come it looks worse now? And I asked her, I said, well, were you standing or laying down when the original x-rays were taken? She said she was laying down. So often we'll see, this is not the same film, but it just shows that non-weight bearing films often will show a joint space when, if we get standing films, we'll see there's a complete collapse of the joint space on that part of the knee. And when we're talking about the knee, the main bones we're dealing with is the femur or thigh bone, the tibia, and the bone you can't see here real well, but it's right in the center, it's the patella or kneecap. We use ultrasound a lot in our practice. It helps us with injections. Also, it's good for diagnostic treatments. I had a lady the other day came in with a cyst around her knee, and we were able to localize it and take the fluid out. So ultrasound is used a lot. MRIs is the fanciest test and very helpful. You can see the difference between an x-ray that only shows the bone, and with an MRI, we can see the cartilage, we can see the meniscus, we can see the, is that arrow showing up there?
Yeah.
Yeah, good. We can see the tendons as well as the ligaments. So we combine all those things, physical exam, history, and those separate tests to come up with a diagnosis. And one way to think about some of the problems that can go wrong, I often say if I wanted a car mechanic to tell me what sort of problems he would see in a car, I'd just open the hood and start pointing to various structures and saying, well, you know, what's that do? The fuel injectors and where's the starter? And he could talk you through it a little bit. So we're going to try and do the same thing with the knee. When you look at a knee, there's several structures. There's the bony structure we talked about, the femur, thigh bone coming down here. At the distal end of it, we see this white material, and that's cartilage. That's sort of like the tread on your tires. And there's cartilage on top of the tibia. And interposed between those two is a structure known as the meniscus. And if you're a football fan or a sport fan, you'll hear about these athletes who tear their meniscus. So the purpose of the meniscus is to distribute some of the force across the joint and help protect and preserve the cartilage, because in the knee you only get one set of tires, so you got to take care of them. This cartilage, when it wears out, you've got some significant problems, for which one of the solutions could be a total knee. There's also other structures, though, that can cause pain. Wherever a muscle, you see the red thing here is your quadriceps muscle, connects into the patella or kneecap, goes into the patellar tendon. We can see inflammation around these tendons. We can see strains of the ligaments that support the leg and hold it all together. In fact, as we go through our talk of some of the treatment options, including the surgical ones, and start talking about joint replacements, I want to emphasize the point that there's 4 ligaments that provide the major support to the knee. There's one on the big toe side we call the medial collateral ligament. There's one on the outside or little toe side. There's 2 crossed ones called the ACL or anterior cruciate and the PCL. And in some of the surgeries that we'll be talking about in the future, one of the important things to recognize is how many of those are preserved, how many are sacrificed or taken away at the time of that operation. So cartilage, important when we're talking about arthritis, meniscal tears, sometimes with trauma, sometimes just with age. Ligament, preserving those ligaments, both from trauma and also from the necessities of certain types of surgery. So if we go back to Sherlock Holmes and talk about the usual suspects in knee pain, we're trying to answer that question: who's the bad guy? Who's causing the problem? And now we've looked at some of these structures. Meniscal tears, very common in younger people, even us older folks get them. In the younger groups, a lot of times I want to hear a story how they injured it, whether playing a sport, did they slip somewhere. As we get older, we can get meniscal tears without even having an injury. So that's a distinction we'll need to talk about when we get into a discussion of arthroscopy. Ligament tears, again, I see people that had injuries, but sometimes they have pain around the ligaments because they have inflammation in those areas where that joint's being overloaded, either due to arthritis, where they're putting strain on the ligaments more than on one side of the knee more than the other. A lot of the arthritis we're going to be talking about, you'll see as a segmental disease, meaning it oftentimes will affect one part of the knee but not the other, where a lot of the people I see have arthritis primarily on the big toe side of the knee, what we call medial, and some will have it only on the lateral side. Some will have it in all 3 compartments: the kneecap area, the big toe side, and the little toe side. So when I see someone, I'm going in the room and I see they're having knee pain, and I've looked at their x-rays, that question: do they have a meniscal tear? Do they have a history of an old ligament tear, or is it inflamed around there now? Do they have arthritis? And do they have loose bodies? A lot of times with arthritis, as a secondary effect, as the cartilage wears off, I often compare it to, you see these big strips of rubber you see when you drive down the highway, and that's a wear product that comes off. Well, some of the wear in the knee where the cartilage comes off the bone stays in there, floats around, irritates the lining of the joint. That lining is called the synovium, and when it gets inflamed, we call it synovitis. It reminds me a little bit of someone's eye when it gets inflamed. We've always seen someone who fell asleep with their contacts in or got an conjunctivitis, and it'll look all red. You'll see the blood vessels, and it'll tear. And when a person gets synovitis in the knee, it produces fluid. I've heard the expression water on the knee. So you can see when you see a doctor, you got a knee problem. The question is, Did you tear your meniscus? Do you have some problem around the ligaments? Is there arthritis? Have some loose bodies come off in the knee that are catching in the joint? Is the joint inflamed? Synovitis. Some of the treatments we give, cortisone injections, some of the gel injections, are really aimed at treating this synovitis. So that's an important part of the whole process. So the question you might ask is, well, what is arthritis? We often the most common type that all of us are prone to get as we get older down the road of life, past our late 40s, 50s, into our 60s, an increasing percentage of us will have some arthritic changes in our knee. Sometimes they'll be minor, won't bother you much. And there's two things going on. There's inflammation and there's the mechanical problem. And I think it's important as we start talking about treatments to make a distinction between the two. Some people, they'll have a lot of inflammation in the knee, but the mechanics are pretty good. In other words, their meniscus is not torn, their ligaments are stable, they've got pretty good cartilage, they don't have a lot of bone spurs, but the joint just tends to get real inflamed. And these joints can be treated very effectively with anti-inflammatories, either pills or injections. Now, like most things in life, it's not often that simple where it's just one or the other. A lot of times it's both. People have a mechanical problem, a loose body, a meniscal tear that's adding to the pain by causing increased pressure on the bone. So I think, when you're trying to sort out the problem you have, I think we have to consider both aspects. This little slide tends to show, it's sort of a schematic, shows a normal knee on the one side and the osteoarthritis on the other side. And we look at some of the structures that are affected by arthritis. Outside of the knee is the capsule. And this is sort of like the clothing that goes over the knee joint. On the inner portion, sort of the lining on that jacket that covers it, is the synovium, that synovitis we were talking about. Then there's the cartilage that coats the end of the bones. It's the tread on the tires. There's the synovial cavity where fluid builds up inside that capsular membrane. And then there's the bone. And all these structures can cause you to experience pain. When you look how osteoarthritis affects those structures, you can see where the cartilage is irregular, where pieces of cartilage have come off, where little fragments can become embedded in the synovium, how the synovium has become thickened, comparing one side to the other. And this thickened capsule, I often use the example of if I said, let's play a little basketball one-on-one, and I'd wear a t-shirt and I'd give you this leather jacket that had been soaked in salt water and gotten stiff and dry, you're not going to be able to move very well. And so the normal capsule is more like the t-shirt. It's flexible and pliable and has the ability to stretch, while the thickened arthritic capsule is really limits your motion and can be responsible for some of the pain. This capsule, we can improve it if we diminish the inflammation early, if we get you on an adequate physical therapy program to keep that stretched out. One of the more difficult problems I see is patients coming in with a flexion contracture. And by that I mean when they walk with their knee bent. It may be rather subtle, but it can be 5, 10, 15 degrees of restriction. And if you want to see what that's like, if you're fortunate and don't have any problem with your knees, try walking around with your knees partially bent. And after a very short period of time, you'll want to straighten out, because that puts extra stress on your muscles. It's tiring. It's painful. So when I see patients early on in the arthritic process and they have a flexion contracture, I want to get them into therapy and stretch that capsule out. We want to get them on an adequate medical treatment program to get the inflammation down. So let's see here. And here's just a summary of some of the things. Osteoarthritis is a term you're going to see a lot, and you'll hear the expression OA. You also hear DJD for degenerative joint disease. It's the most common form of arthritis, known as wear and tear. It's a highly segmental disease. And that's something I think it's important to keep in mind. I've seen a lot of patients who have underwent a total knee replacement, and where some of us would recommend for their consideration a partial knee replacement. Just replace the segment that's worn out. If it's only this side and you've got pretty good joint space over here, you can make a much quicker recovery. You can retain those 4 ligaments instead of sacrificing them. You know, some of those knee replacements require you to we can only save 2 of the ligaments, or with a partial knee we can keep all 4 of them. But with chronic inflammation, the joint becomes pitted, eroded, uneven, and then it generates pain through a variety of mechanisms, including mechanical and inflammatory. We see bone spurs, osteophytes they're called, form around the joint, and they can add to irritation of the capsule and restrict motion. So that's osteoarthritis. Now, what do we do about it? That was the second question. So we've made a diagnosis and it's arthritis. Let's say it's osteoarthritis. And we can look at what Shakespeare said, there's more things in heaven and earth than dreamt in our philosophy. And certainly you want to be able to go to someone and in your own mind have an understanding of what the possibilities that exist for you to consider. My grandmother, we called her Mamaw, she always said there's more than one way to skin a cat, and I try and keep that in mind when I see patients. So again, early in my practice, occasionally I'd see someone, after they had left, I think, oh geez, I should have mentioned to them this other possibility. So just as a little reminder, since I had 5 fingers to look at, I thought, well, what are the things that I do all day long? And basically it fell under these categories: medications, injections, braces, physical therapy, and surgery. And to me, that prevents me from focusing just on one thing and making sure we look at a complete offering of approaches to the problem instead of just one. Medications, there's the most common thing you're going to get if you see 10 different doctors, you're probably going to come back with 10 different arthritis pills, but they all fit into the general category of NSAIDs, which stand for non-steroidal anti-inflammatory drugs. And what that means is they work through a system of chemicals called antiprostaglandins. Won't bore you with that, but the common ones you're going to see at the grocery store: Motrin, Advil, Aleve, and there's probably 80 to 100 different commonly prescribed ones that can be helpful. They do have significant side effects and risk for some people. If you're diabetic, you've got to be careful taking those. It can affect your kidney function. You need to get your doctor's, your internist opinion on the advisability of you taking them for a prolonged period of time. Once we get beyond the age of 60, our renal function, kidney function goes down a little bit. I mean, it works fine, but you don't want to keep flogging those kidneys with too many anti-inflammatories. There are some other things you can do that might be a little more direct and avoid taking the pills. Voltaren gel. Now, Voltaren's been around a long time. Diclofenac has been a pill, an excellent, helpful in arthritis. But when you think about it, you take the pill, it's absorbed into your blood, and it goes to your brain, your liver, your spleen, and you just want it to go to your knee. For some folks that have the pain localized to one area, this gel can be used, and it crosses the barrier of the skin and has been good for some patients. I get asked a lot about this non-prescription glucosamine chondroitin sulfate. It's been studied quite a bit. My opinion of it, it's worth a try. If you take the pills to avoid choking to death, because they're pretty large, take it with some applesauce. And actually, you can swallow it a little better than taking it with water. It's part of your swallowing mechanism. Anyway, it's a non-prescription item. It doesn't regrow cartilage. It doesn't build your knee up again, but it can have a mild anti-inflammatory effect. And I don't see much in the way of side effects other than the size of the pill. So that's medications. Injections. There's a couple different types of injections. Cortisone, most common, very effective. I like it many ways. For a lot of my patients, I can give them a shot of cortisone in the knee, And nowadays we have this water-soluble cortisone. It's a real small needle. We use ultrasound to inject it, and I think it, in many ways, is safer because you don't get as many of the side effects as you would if you took an anti-inflammatory pill. Viscosupplementation, big sounding word. Basically, a fellow in Europe some years ago did a study looking at the joint fluid. The joint fluid is secreted by that membrane we were talking about, the synovium, and it was low in a chemical called hyaluronate. And so he found a way to extract it, originally from chicken parts, that comb on a chicken, that red thing. And they've got other ways to do it now, but they purified it and concentrated it. There's several brands of it. You'll hear Supart, Synvisc, Halligan, Orthovisc, and they all say they're better than the other one. I don't know if there's any great difference in them, but the purpose of it is to replenish that chemical in your knee. And with patients that I've treated through 15 years of giving these gel injections, I'd say about 2 out of 3 people seem to be helped by it. It's not a miracle, but it does certainly help a lot of people keep going, and I think it's worth considering. Platelet-rich plasma is one of these things that you hear about with the athletes. The idea was that platelets are involved in healing. Whenever you cut yourself and bleed, the platelets are in the blood. If you concentrate those platelets, there are chemicals that can be released. These are just some of the gel injections. And it's your own blood that we take it from, so it's safe that way, and re-inject it into the knee. Medicare doesn't pay for it. Insurance companies don't pay for it. A lot of folks would say it's experimental, and I'd have to agree in the sense that there's not good evidence that it's that consistently successful. The other thing you hear about nowadays a lot is stem cells, and I've seen the advertisements for it. Again, they're not going to pay for it. The stem cells, where they take it out of your bone marrow or sometimes take it out of fat cells, the idea is you take these cells that could conceivably regenerate. It's a little expensive. I've seen prices everywhere from $3,000 to $9,000 comes out of your pocket, and to me there's not enough solid evidence thus far that it's going to cure anything, but who knows what the future holds. So there's just some things about platelets, and I've used it in some patients. And while it certainly doesn't reverse their arthritis, some of them say it's sort of like the Starbucks coffee you get in the morning with caffeine in it, sort of the caffeine for your knee to stimulate some products that may diminish the inflammation in your joint. So now we're down to the third finger here, bracing. And I recommend trying them. Often start with the less expensive ones that you get at the Jewel or Osco's. You walk in, and the section there, you see these elastic braces, and it's worth trying. Lots and lots of studies have been done to show that if you put one of those elastic braces on and try and do some exercises with it and without it in an arthritic joint, the people with the elastic braces on seem to do a little better. It's hard to say why, but don't see any downside. They're fairly inexpensive. There are more complex braces. This is this red one we see here is what's called an unloading brace, and these are meant to sort of like rotating the tires. When I was a kid, I used to do with my dad. You'd try and even the wear out, and the idea is if one side of the knee is worn down more than the other, if you can use that brace to push the knee over to the good side, it may diminish the load and diminish the pain. So it's certainly worth considering. I find for a lot of my patients, male patients, some of them who are, and women too, but if they're in the trades, these can be helpful. And they are expensive. Sometimes the insurance companies will pay for them, and sometimes they won't. Physical therapy, I think, is underutilized for arthritis. And talked about some of the problems I see, that capsule gets tight, the knee gets constricted, and you don't straighten it out, you don't bend it as far. Those are things that are going to make everyday life painful, and a good therapist can if you get to them soon enough, can stretch that out. Again, a lot of studies have shown if you work on the big muscle in the front of your knee, your quadriceps, and the hamstrings, those long muscles in the back of the leg that bend your knee, that if you increase the strength of them, no matter what age you are, you can help yourself. And I think as we get older, there's a tendency, I guess they used to always say it about the boxers, they'd lose their legs first. I think for all of us, as we get older, if we want to maintain our mobility, I think strengthening legs is good for us anyway, but it's particularly good for the arthritis. And oftentimes we have a program, I call it Knee School, I like patients to go to, and the idea is to get them to get a thorough evaluation of the relationship between their hip, their knee, their foot, and their ankle. There are some corrective things that can be done by a physical therapist to help you with that. So get your range of motion, strength. Isokinetic exercises are important. These are exercises done with speeds incorporated. So a lot of things in life, it's kind of an isokinetic thing. If you stumble on the stairs, you're going to have to contract those muscles quickly, and the more you can respond in a timely fashion, you can help keep yourself from falling and get rid of those flexion contractures, which is a painful way to be walking around, and it also it's more likely to give out on you. Flex knee. When I was a kid, we used to walk up behind the other kids on the playground, and if you'd hit them in the back of the knee, it'd cause their knee to fold up, and then they could fall. So we had some mean kids at school. So medications, injections, braces, physical therapy, and then every surgeon's favorite subject, surgery. Arthroscopy. What is it? What can it do? Well, there's a variety of things. And we'll kind of briefly go through them, and we're going to leave some time here at the end for questions, so maybe that'll be the time we'll get more specific. But the more common thing you hear about with the athletes is tearing the meniscus. That's that pad I was talking about that sits between the two bones. And if it's torn, it can catch in the joint and cause pain. In older patients with arthritis, the same thing can happen. And that's part of the thinking I want to kind of expand on. I think oftentimes people get labeled as having arthritis, so anytime anything hurts them, they go, well, it's your arthritis. Well, sometimes it's not. Sometimes it's the synovium, that lining in the joints inflamed or thickened and catching in the joint. Sometimes a torn meniscus. Sometimes those loose bodies. So arthroscopic clean out of those joints can be helpful. I know there's been some controversy back and forth, but I'll show you here in a little bit. There's plenty of papers indicating it can be a very effective means. Then we get into the procedures that are intended to restore cartilage, and most of these are for very limited areas in your knee. Microfracture, autologous cartilage implantation, something I went to Sweden to learn how to do some years ago, and mosaic plasty, where we take, it's almost like the hair transplants where we take hair from the back of us balding fellows and put it in the front. The mosaic plasty is a similar thing. We're trying to take it from a less used part of the knee and plug it in, and it can be helpful. Again, some of those things would take a whole talk itself. And then at the end here, so we're going to talk about arthroscopy now, and then here's those tread tires I talked about being left in the road. And that's what happens with arthritis. Now we can go in with a scope, and this kind of shows a little cartoon version. You can see the kneecap here. You see the scope down here, the instruments we bring in from the other side. This is a whole area that I have found through the years to be very helpful. To me, arthritis is a slowly progressive disease in most people. During that time, patients go through different phases where initially pills and shots can work, braces can help. As time goes on, some of these knees, I believe, would benefit from being cleaned out, arthroscoped. You need an MRI to see what's going on first, but certainly worth considering. Here you can see the meniscus. So we can see all these things through the scope, and we can address some of those problems arthroscopically. What are the results? Well, here's some studies. This was a fella at the Insall Scott Burstein Institute, a famous place for knees. They did a study, looked at their patients 10 years after arthroscopy, and saw out of 77 patients, 91 knees, because some of them were, both sides were done. they found that 2/3 of those people in that 10-year period didn't go on and have a knee replacement. That about 60% of them had no additional surgery because some of them went on and had something else done again. A third had their total knees done, but it extended out to almost 7 years before they had it done. So that's encouraging. We see this, several other papers. You see these authors looking at their results 2 to 4 years from the time of arthroscopy. So I think what's the message here? That there are arthroscopic surgical procedures that can help a painful knee that also has arthritis. It's not, going to, there is no perfect cure. And to me, if I had an arthritic knee, I certainly would give serious consideration if it looked as though I had some issues that could be addressed arthroscopically. And I'd get an MRI first, and I certainly would give serious consideration to having it scoped. So here's, when we talk about meniscectomy, what we're doing, we're just trimming up these tears that occur. A lot of times there's, this shows rheumatoid synovitis, but there's some studies from Stanford recently showing cytokinases and inflammatory chemicals within the knee. And I often see this, and we clean these out, and it does help a lot of people. So some people say it's temporizing, but most things in life are temporizing. And I think that's the secret, is try and relieve your pain presently and hopefully get some long-standing improvement for several years. And some of the studies indicate that. So worth thinking about. The debridement, we put in these instruments almost like a vacuum cleaner, and it sucks some of those loose bodies out. We clean out the synovium, we trim up the torn meniscus. Here's what it looks like. This is normal looking cartilage, just beautiful white, smooth tissue. Here's what the meniscus should look like, which is the pad in there. Here's what some of the, this is a few years ago, I took these out of a person's knee as well as trimming up their meniscus. And it shows these fragments that are floating around in the joint. They get embedded, sort of like if you were in a dust storm and got dust in your eye, you'd want to wash it out. And removing this is helpful. Where did these little joint mice come from? Well, here it shows you where they came from, this big ulceration. That's like a pothole, and that's on the knee surface. We talked about cartilage, and it should be fairly thick, and here we're down essentially to bone. There are ways to try and stimulate that area to grow again, and this thing called microfracture, where we actually drill holes in it. The person has to be on crutches for around 6 weeks, so it does take time, and it's certainly not a magic perfect cure. This is the ACI. We talked about autologous, meaning it's your own cartilage. These cells are taken, sent to a lab in Boston that does cell culture to, it's sort of like taking a cutting off a plant and getting more plants, and we get more cells that way, and then we can replant them back in that area. We have some material, we sew like a patch over it, inject the cells. This is that mosaic plasty. I was talking about the hair transplants, where basically we're just taking cartilage from different parts of the knee and putting them in the worn spots where there's more pressure. Unicondylar partial knee replacement. This I was mentioning that osteoarthritis is a segmental disease. There's three, you might think of the knee as a 3-room apartment. There's the medial big toe side. You know, if you rubbed your knees together, that's the medial side. If you reach down and clap the outside of your knee with your hand, that's the lateral side. And then there's the patellofemoral, which is underneath your kneecap. That bone sticking out that you hit run into into the tabletops or something. It hurts so much. So those 3 areas, and some people will predominantly have arthritis in one of them, but not the other. That's what I call segmental disease. Here's an example, this classification system that's often used. And you can see very minor narrowing here. You see how it advances, and then it gets down to bone on bone. And of course, if you just let it go, it can erode into the bone. Here, there's nothing left but a total knee. This area here, you could do the partial and restore the alignment. It's sort of like if you saw your car was out of alignment and wheels needed balance, and you might do that before, get it balanced before you lose the tires. Here you've kind of worn everything out. So what we do is just address the one segment of the knee. It's not quite as easy a rehabilitation as arthroscopy, but it does restore balance to your knee. It allows us to deal with that sclerotic hardened bone that forms in areas of arthritis where there is no cartilage. It's a segmental treatment of a segmental disease. In other words, if only one side of your knee is worn out, I guess if you say one tire was bad and all the others were okay, that's probably the only one you'd do. It preserves bone for the future. A lot of people who find themselves in the unfortunate situation where they're down to bone on bone, all the other treatments haven't worked, they're looking at possibility of a knee replacement, very likely they're going to have that revised. It's much easier to take a partial knee replacement 20 years from now and turn it into a total than it is to take one total, take that one out and put another total in. You lose a lot more bone that way. This was a study, it was done in Sweden. This is a Venn diagram, for those of us who remember Venn diagrams, but basically the one circle here is to include everybody out of 370 that had arthritis in the medial compartment. Now this 166 here, there's no overlap with the others. So of those, and this is the most common area where I see isolated arthritis, 166 were just, so all these people out of that 370 would be considered candidates for a partial uni. When you get some overlap, you know, people in this category here have arthritis in the kneecap and also in the medial compartment. So you have to address the different segments that are involved, but this is the most common. We see all the time, worn out medially, bone on bone. I did a couple patients recently that had they had their opposite side done, total. In fact, they'd used what was called a posterior stabilized, which left them with only 2 of their natural ligaments. On the other side, I did the just the partial, and they have all 4 of their natural ligaments. And I think that's an advantage in terms of the knee feeling more like a normal knee, what we call proprioception, knowing where your leg is in balance. I've never done a uni on someone where they've had a total on the other side and a uni on the side of did that they didn't. The person always preferred the uni. So when possible. Now if you do a uni in somebody who needs a total, then it's not going to work out. But anyway, it's something that you need to be aware of. You can discuss it. There's a lot of literature on it. It's, you know, there's some doctors who just feel that you might as well do the whole thing. But I can tell you personally, if it was me, if scoping didn't work and all the other things didn't work and I had only one segment, this is what I'd have done. And what's the follow-up like? Well, 21 years, 86%. 15 years, 86%. Berger, one of our famous Chicago surgeons, I think he did the president recently, excellent surgeon, but he had 96% survival, 15 years. We use the same system. It's that he's used for this study called the Zuck or Zimmer unicondylar, and it's been a good implant. It's held up. So there's some other doctors that have done them, and you can see up to 90% survival. So that means if you start with 100 people, 20 years later, 91 of them are still going with that implant. And at 20 years, a lot of the total knees are going to be worn out, so I'd rather do the uni to a total than the other way around. So the other thing was interesting with some of these studies was the high percentage of excellent rating. In other words, when you went through a rating system, and here's for a uni, 71%, and I've seen in Berger's group, I think it was 80-some%, had an excellent rating. In the total knee, it was only 53% excellent rating. So you see more complete satisfaction with the unis. Total joint, excellent operation. There's a lot of factors to consider. There's not just one type. Are you going to have a cruciate retaining? Are you going to have a posterior stabilized, constrained? And that's something that is worth at least thinking about. I use the CR a lot because I think that, again, we can preserve 3 out of the 4. A lot of doctors, there's not, I shouldn't say a lot, but there's probably at least half or more go straight to the posterior stabilized, and that leaves you with just 2 of your normal ligaments. Some think that's better, removing what they consider diseased tissue, but I do think that with the CR knees we can balance them out pretty well. And again, if it was my personal choice for myself, I'd go with the CR unless I did not have the posterior cruciate left. So when you do this stuff, when you do a knee replacement, too early, too late, both can create a problem. If some of the studies have shown that when patients had total knees before their arthritis had really progressed to the point where that seemed appropriate, they weren't satisfied. And if your pain level is a 7 or an 8 and it gets you down to a 1 or a 2, then you're happy. If it's a 3 or a 4 and you go down to a 1 or 2, then you're kind of disappointed after going through all that surgery. So you have to kind of figure out what category you're in. I always start with a CR when I'm going to do a total, unless it's just obvious that they're going to need something more, such as constrained or a PS. I use this system called Visionaire. I think it's through the years, 30 years of doing these, I've seen a lot of improvement in the accuracy of putting the implants in. I think that's probably been the greatest improvement. It's like any other mechanical thing. If someone built your house and didn't, the doors weren't hung square, you're not going to be happy. And same with the knee. There's a mechanical axis that runs from the center of the hip to the center of the knee to the center of the ankle, and you want to get it lined up. And these are made for each patient. We get an MRI of the patient's knee, and then these are made by this printing process, 3D printing it's called, and we use them during surgery. Very helpful. So I think those are things that can help. The patient matched technology. I think some of the other things, I don't use a tourniquet, haven't used it for years. I think that helps diminish some of the pain. A lot of times with the tourniquet up, it can be up for an hour or so, and those muscles aren't getting any blood to them. There's no antibiotics perfusion. So I think there's some advantages. I mean, a lot of doctors feel they still they want to use the tourniquet. There's nothing, I don't think there's anything wrong with it, but I just think there's some subtle advantages whenever possible not to use it. Type of implant you put in, the FDA has only approved one to advertise themselves as a 30-year knee. It's coated with a thing called oxinium. That's what I use. It has lower wear. It's sort of like if you put a lot of mechanical things, whether it's an airplane or a car, put on these Instrom testing machines, and they run it so many million cycles. And they might do that with a car tire and just say, well, this car should last 75,000 miles. They did it on one of these implants, looking at the wear on the plastic part, and it proved that with that oxinium coating, these things could last up to 30 years. So the Visionaire technology, getting them lined up well, using these, I think has been a great advantage. And this is one of the many things we're trying to do to get these things balanced out correctly, looking at the mechanical axis, the anatomic axis, the epicondylar axis, these different bony landmarks. We won't get into the specifics of how to do a total knee that much, but these have been great. These are the kind of pictures we get beforehand, so we know pretty much what the size is going on. We know what the cuts are going to be, and the better we match them, I think the better people do. So that's the 30-year knee. Oxinium is the material. It's made by a company called Smith & Nephew, no relation. Now, some people can't have MRIs. I've got a couple people coming up, and for years I've used the computer-assisted navigation, and I think it gives excellent alignment. I think it's in many ways just as good. It just takes a little longer, and it's not that much longer, but when a person can't have an MRI, we'll use this system. And this kind of pictures we get during surgery, so when you adjust it, you can see right, the often overused term of real time, you can see what's going on and get the thing mechanical axis. That's what it looks like. It's just this little diodes, light emitting diodes we have on the thing, and this senses them, and we have a screen we watch, computer assisted. So if you're going to have a total knee, you want to go someplace where they do a lot of them. That's one of the messages. A lot of studies. Ingalls is a high volume. They've gotten a lot of awards for their joint center. Real nice rooms, accommodations. Got a nice view of the outside here, and very pleasant. Everybody gets a single room. There's we have a special floor where we just have the joint patients. No one with infections is allowed on it, and that's gone a long way to diminish risk to our patients. So I think that's a real advantage. Know where you want to go. Remember Ward Bond and the old wagon train story? I grew up watching that. It's important too, when you're having something done to your knee, you want to know what your goals are. If you want to play with the grandkids on the floor, if you want to, golf, if you want to play tennis, get a sense of, out of these various options, what'll do the job for you. There's no use putting a racing transmission in a car you only want to take to the grocery store. And if we can get you comfortable in one of these other ways and save you having an operation, then certainly we want to consider it. Here's an 80-year-old guy that I did a knee replacement on, and I'd like to take all the credit, but he's a man who's obviously a very good water skier his whole life. But so that was his goal, and he got back to it. Well, this is the part we always like to leave time for some questions and see if there's anything I confused you with too much. Just let us know.
Please feel free to type your questions in the chat window. Let's see, we have only gotten one question so far, and she asks, what can be done about loose cartilage?
Well, let me answer it this way. Make sure I'm responding to what you want to know. The old expression for a torn meniscus used to be torn cartilage. And so if that's the problem a person's dealing with, if someone told you have loose cartilage, you want to make sure that you're understanding whether it's your meniscus or whether it's the cartilage that coats the bone. The short answer to no matter which it is, in terms of doing anything about it, in other words, if you're having symptoms, then arthroscopy would be the approach. Now, just because you have a torn meniscus, not everyone needs to have it operated on. There's some patients I've given shots of cortisone and quieted down, and they did okay. So you have to individualize these things, but in general, if it's persistently causing you a problem, arthroscopy would most likely be the approach I would take.
Okay, looks like a couple other questions have come in. I live alone. What can I do if I have surgery? How can I stay at home, and how long will it take to recover?
Sure. Well, I always struggle a little bit trying to answer some of those questions because everyone's different. But let me say this. Ingalls has a good program, and I know a lot of people complain about Medicare, but actually it works pretty well. And that is Medicare will cover most people with a total, we'll start at the hospital. Usually you're there 2 or 3 days after a total knee. And most people can get up and get around on a walker and do pretty well. Because the truth of it is, most people that are having a total knee have been struggling to get around for some time. So it's not new territory to them. They've struggled with stairs, they've struggled with flexibility. And of course now it's a little different problem because they've just had an operation. But after 2 or 3 days, most people are independent enough to go directly home. Ingalls has a program where they have a visiting nurse and a physical therapist comes to your house, and I believe they can at least get you up to 2 weeks of treatment that way. So with a little planning, most people can, for me it would be some Wonder Bread and bologna, and I could get through. If I stocked up the refrigerator and someone came by every once in a while and changed my bandages and check on me, and you'd be okay. A lot of patients really can get out of the house. And if you have some family help, it's not that someone needs to be there all the time staring at you. They can, you know, somebody can drop by and ask you how you're doing, give you a call, or send you a text message in our modern communication system, and you can let them know whether you needed something. But it's so it's 2 to 3 days. Therapy usually runs. I have all my patients use a walker or crutches for 4 weeks, and I'm on the conservative side. I just think you're less likely to fall and have a problem, even though most patients could walk without that much sooner than that. I just like them using the walker or crutches as a safety thing. Physical therapy is usually anywhere from probably 2 to 3 months. Again, depending. If you're like the water skier, you're going to go a little longer. If you're the guy who just wants to play with his grandkids, you probably get it done in 6 weeks or so.
Great. We've gotten a couple more questions coming in. Are there times when arthroscopic surgery may need to be repeated? I had one in 1989, and my knee has been bothering me lately.
Well, that's a good endorsement for arthroscopy, 1989 till now. Yeah, I mean, I've had a lot of patients. I mean, you know, I've kind of grown old with a lot of my patients. You know, I started out seeing them, and they had some issues that I saw a lady 30 years ago. We did something with her ACL, and seeing her now, and she's getting close to having a knee replacement. But during those 30-some years, she's had her knee scoped 2 or 3 times. So the answer to your question is yes. I mean, it's Dan Hampton, the fellow who played for the Bears. I heard he had his knee scoped 17 times. Seems a bit excessive, but it allowed him to continue to play at a high level, I guess. So might have been worthwhile. Yeah, I'm a firm believer in the use of arthroscopy as a reasonable means to help manage arthritis, because that's really what all this is about. It's management. There isn't any one cure. Even total knees, when you look at them, have about a satisfaction rate of probably 80-85%, meaning 15-20% of people are not satisfied. Now, we all know certain people you can never satisfy, and some people, they could have done a better job in therapy, or maybe the doctor could have done a better job doing the operation. But whatever it is, there's none of these treatments we've talked about is 100%. But arthroscopy at least doesn't have a steep downside. From my experience, certainly you do get, those papers we looked at before were probably in the range of 2 out of 3, 3 out of 4 people benefited, meaning 1 out of 3, 1 out of 4 didn't benefit from it. But for the vast majority of them, they were pretty much back where they started. Certainly they'd wasted their time, but I think it's worth considering. So answer your question is yes, it can be repeated.
Okay. Next question. Recently, I had surgery to repair torn cartilage, but I'm still having severe knee pain where I am having trouble walking. The initial diagnosis was a bone bruise. I have gotten a second opinion and another MRI. The MRI post-surgery has detected a case of severe arthritis, but not so severe a knee replacement is required. The doctor has recommended shots. I have had cortisone shots in the past, and they seem to last less than a day, and I am back in the same situation. The doctor has talked about gel shots in the joint. What are the benefits? Can you anticipate pain-free knee, or at least pain reduced so I can at least walk and get exercise, building up muscles in the leg again? And how long after the shot can I regain normal activity? How often do you recommend the gel shots, and can the gel shots harm the joint in any way?
I've been doing those injections about 15 years when they first started. It has been helpful. If I had to give a number, if you wanted some probability or odds on it, I'd say in my patients with arthritis, as a general number, I'd say about 2 out of 3 people would say it helped them. And helping doesn't necessarily mean pain-free. It means it was better now than it was before we did them. There's a wide variation, I'll be honest with you. And obviously, you want to listen to your doctor, not some guy on the microphone. But my approach is, and I have that experience sometimes where you scope someone's knee, and if you scope someone's knee and they have a torn meniscus, sounds like you had a torn meniscus. And if they have arthritis with that torn meniscus, then the certainty of 100% improvement is less. So in other words, if I do a young person, doesn't have any arthritis, you deal with their meniscus, most of those patients are going to do real well. Someone who's got arthritis and a torn meniscus, a lot of those people can be helped, but you're not going to necessarily solve the arthritis problem. It many times is a multi-pronged attack. Well, the first attack is take care of the meniscus. The second is try and deal with the cartilage problems. And I think the treatment that your doctor has suggested to you, the injections, is I probably would have told you the same thing based on what I'm hearing here. So how often can you have them? Well, the FDA and the insurance companies and the Medicare say 6 months because they're not going to pay for it any more frequent than that, and the studies don't indicate that it's useful to do it any more often than that. So every 6 months, the duration. I have lots and lots of patients who get it once a year, once every 2 years. So it's common to repeat it.
So there's a follow-up question. Does the gel dissipate with the gel shots? Does the gel dissipate over time, or do you keep pumping in more gel into the joint? And also, will it swell or fill up?
Sure. The purpose of, yeah, you're exactly right. It does dissipate or go away. Your body resorbs in a fairly quick fashion. I forget the exact time period. I think it's 1 or 2 weeks. It's pretty much out of your system what they put in. The idea, it's sort of like priming a pump. The hope is that you're going to stimulate the synovium, the lining of the joint, to start producing that hyaluronate again. So that's the mechanism. So it does go out of your body. It goes out fairly quickly. Does the knee swell? Very seldom do I see that. I mean, I've kind of switched between the different agents over the years, and one I used, I found occasionally you'd inject some folks and they'd come back and say, well, it hurt worse for a short period. The ones we're using now, I don't see that much at all. So I wouldn't expect swelling. As for activities, a lot of my patients come in after work, they go home, they go to work the next day. I wouldn't suggest, going bowling or going to the volleyball tournament that night, but once you've had 1 or 2 of these, pretty much have an idea how you're going to respond. So don't see a lot of downside. Occasionally, we do get patients who come back and it caused a little flare-up, but that's a lot less common than it used to be. So it's usually 1 shot a week for either 3 weeks or 5 weeks. Those are the 2 protocols. There is one brand that has a 1-shot deal. I haven't found that to be as effective. So most times it's once a week for a period of either 3 weeks or 5 weeks.
Great. What is the life expectancy of the injected chicken comb solution?
Yeah, that's I may be misquoting here, but I think it's about a week or 2. It's something that's put in to stimulate a response, and you want to extend it over a period of time of either 3 weeks or 5 weeks. So it's only in there. It's not a permanent thing. And I know patients sometimes, I think, believe that somehow it's a gel that sort of, floats up the space between the bones and fills the gap with this kind of foam cushion. It's really not that. It has more of an effect on frictional, more on lubrication, a little bit on nutrition, than it does on mechanically changing the joint space.
Okay. Next question. I had a doctor tell me I needed meniscus tear surgery. Another doctor told me that I needed to have knee replacement. What should I do?
Well, that's hard. There are many times where it's uncertain what's the best. And this is something that's discussed all the time. Patients who have arthritis and a meniscal tear, some feel that you shouldn't have, that if it's moderate to severe, that treating the torn meniscus is not going to help that much. And if you're going to require treatment, why not just go on and have a knee replacement? I can only say that if it was my knee, what I would, my preference, and each patient just needs to know the facts. And that is that if you have arthritis and a meniscal tear, there's some uncertainty. And the response, you might get down into the 50-50 kind of category where you might as well flip a coin as to whether it's going to work or not. But if it were me, I would have it scoped and see how I did. Of course, you have information I don't have. On the other hand, if I had had this problem for a long time and the meniscus tear was just a recent aggravation and I'd been thinking about getting my knee replaced, this might be the deciding point for you. But in general, if there's any question that I think I could be helped with the scope, I'd probably go with the scope first. That'd be me.
Okay. Does repairing a torn meniscus affect the cartilage in a negative way?
Let me start with this. Having a torn meniscus affects the knee in a negative way. So that's the original problem. And I've often said this to patients. There was an old game show where you had 3 doors to pick things. And if one door was a knee with a normal meniscus, and the second door was a knee with a torn meniscus, and the third door was a meniscus that had been operated on for the torn meniscus. So that's the operative knee is number 3. The torn meniscus with nothing done to it is 2. Always go for door 1, the normal meniscus. Trouble is, you can't have it. So you got a choice between the tear and the one that's been treated surgically. As soon as that meniscus tears, there's a thing called hoop stresses, and I won't bore you with that, but it's just basically it's a cushion, and once there's a tear, you've lost the integrity of the meniscus, and there is no way, the vast majority of cases, to get it back. So the repairs are not truly repairs as much as they are sort of salvage for what's left of the meniscus. I think the advantage of getting it done is it seems to offer some hope that you're going to stop the tear from extending and getting bigger and losing more meniscal pad. It also that some tears actually accelerate arthritis. So I do think in ones that are symptomatic and reasonable size that don't respond to simple injections, that you're better off getting them scoped.
Okay. When it comes to using Voltaren for treating knee pain, do you recommend gel or pill form?
Well, for me, and I've used the Voltaren gel, we just rub it on. I kind of like that in a sense. It's fairly superficial. We're all shaped different and built different. And if it's an area of your knee where you can almost, put your finger there and kind of feel the area that's tender, I would try the gel. I think the advantage is you're not going to get as much spread of it through your entire body. Not that these things are deadly chemicals, but a lot of us have problems like GERD, when you lay down at night and you ate too late and it bothers you, that esophagitis. So taking any anti-inflammatory could irritate that. People can get ulcers, can affect your kidneys. If you use the gel, most of the action is going to be right at the area. It's not going to, you're not spreading it through the entire body. So you get less side effects. The only problem is that for some people, the depth of penetration isn't satisfactory. But I'd give it a try on the gel first.
Okay, thank you. I have seen advertisements on TV for a, quote, new procedure that eliminates the need for knee surgery. I'm not sure what it involves, but it sounds interesting. Are you familiar with this process and what it involves?
Well, not really. I mean, I know there's several things that commonly patients come in and ask about. One of them is what essentially ends up being the gel injections, and there's a group that uses fluoroscopy, in other words, an X-ray to inject it. And so there's that. You'll hear occasionally. There is some interest lately in these what's called stem cells and different ways. The one way that's been used is a company, I think it's called Regenix, has done some advertising. And again, I don't think I'd be wrong in saying there's not a lot. If you've tried to find some scientific literature and what we call peer-reviewed peer-reviewed journals where neutral people are looking at the research to see if it was done well, there's not a whole lot to support the stem cells yet. So that may be the thing you're hearing about. And of course, the sad part, if it is that, and you want to give it a try, it can be kind of expensive. I've heard a wide range of prices, everything from 3 to 9. 3 to 5 was probably a little more common. As far as I know, Medicare doesn't pay for it, insurances don't pay for it. And the idea is to take some bone marrow cells out, which to me strikes me as a little bit of surgery, and then they concentrate it and inject it into the knee. I think they've also done it with fat cells, adipose tissue. So I really don't know which particular miracle they're talking about, but there's one every few years we get a new miracle coming out.
We have a follow-up question about the gel shots. Just to confirm, the gel shots are a shot a week for 3 to 5 weeks. Is that correct?
Yes.
Perfect. And the next question, I had an X-ray. The shots, and received shots, Synvisc specifically, in both knees. Do I have to have an MRI now to know the best treatment that is needed to get relief? Currently I have to wear a brace for stability.
Well, let's see if I answer that. And again, I always like to say this. I mean, if you got a doctor taking care of you, he's going to know a lot more about you than I am, just, getting a few facts. So go by your doctor and don't go by me. But basically, if you had Synvisc, no, you don't routinely need an MRI because of the Synvisc, because of the use of the Synvisc, you don't need an MRI. It's just you might need an MRI to further investigate what's going on in your knee. In other words, let's say if your doctor looked at your x-rays originally and said you had some arthritis and suggested trying the Synvisc, and you're still having some residual problems, well, then an MRI is certainly reasonable to do because you might have a meniscal tear, there's a thing called osteonecrosis. There's some other diagnosis that might come up. If you have an instability, you might have a meniscus tear. You might have a ligament problem. So I think an MRI would be a reasonable thing to do, but it's not necessitated or caused by you having Synvisc. It's just, you've had a treatment and it hasn't completely resolved your problems. So the question is, what can you do next?
Looks like our last question is, where is your office?
Well, right tonight we're in Homewood, Flossmoor, and on Saturday and Monday I'm in Oak Lawn, and we have offices in Oak Lawn, Homewood, Flossmoor, Calumet City, and Orland Park. So there's several of us, and we're at all those offices, but I'm mainly at Homewood, Flossmoor, and Oak Lawn.
Okay. Thank you very much for your time and for answering everybody's questions. Everybody, thank you for joining us. If you have any further questions, feel free to check out our website. It's on the screen. And there's our phone number. Thanks again.